peptic ulcer diseases. It is now becoming a great challenge. We're having resistant cases, we're having treatment failure cases. But what do we have to know? Two challenges we face. One, eradicating the H. pylori, the bacteria. Number two, healing the wound. We start with the first one, H. pylori eradication. As medics, we are well conversant with the triple therapy treatment. The triple therapy has its own challenges, but today you will hear what you have never heard, maybe. You will know what you have never known, maybe. And then it can help us to further see how we can battle with the emerging H. pylori resistance. We have the triple therapy. We have the first line standard triple therapy, which includes the clarithromycin 500 milligrams twice a day, amoxicillin 1 gram twice a day, and a PPI that is given for 10 to 14 days. That is our first line standard triple therapy. But we also have a first line triple therapy which is consisting of amoxicillin, metronidazole, and a PPI. That is according to the Uganda clinical guideline. But now why we are saying that the one having clarithromycin is our first line standard is because when we take a look at clarithromycin itself alone is having an eradication rate of 40 to 60% on the H. pylori, the bacteria. And yet when we take a look at metronidazole, metronidazole is somehow unique that in developed countries where metronidazole is not so much used, we find that in H. pylori isolates, 70% of those isolates are sensitive to metronidazole. But now when you come to developing countries like ours, the case of Uganda, when you get the H. pylori isolates, you find that up to 80% of these isolates are resistant to H. pylori. So you find that the metronidazole based therapy is having its own challenge. That's why we are saying that the first line standard triple therapy should be the one with clarithromycin. Though clarithromycin also has its own problems, then we can go to the first line if we detect a high clarithromycin resistance rate, or if we detect that there may be high clarithromycin resistance. Our first line will be amoxicillin 1 gram twice a day. We add their clarithromycin 500 milligrams twice a day. Then we add a metronidazole 500 milligrams or 400 milligrams. As for the case of Uganda, our formulation for metronidazole is mostly having 400 milligrams because we have 200 milligrams a tablet, so 2 would be 400 milligrams. We still do it twice a day. Then we add on a PPI that still goes for 10 to 14 days. That is our first line if we detect that there might be high clarithromycin resistance. But we should note that the clarithromycin that is mostly being used in research is the clarithromycin of 500 milligrams, where it gives us an eradication rate of about 90.8%. But the 200 milligrams gives us about 88.5% eradication rate, though we fear for resistance. And then we should put in mind that the clarithromycin, we can only use the clarithromycin based therapy in areas or cases where we are sure that clarithromycin resistance is less than 15%. We agreed that we cannot start a clarithromycin based therapy, whether triple or quadruple therapy, where the clarithromycin resistance is expected or is predicted to be more than 15%. We don't do that. But now, that would be our first line therapy for H. pylori eradication. One thing we should know is that in all cases, we are seeing that we are putting in amoxicillin. Amoxicillin itself as a drug, when you bring it on the H. pylori, amoxicillin has a unique feature is that when taken orally, it is secreted in the gastric juice, meaning it is going to be available in the stomach for action against the H. pylori. Then you find that H. pylori is so sensitive to amoxicillin. But the problem with amoxicillin is that when used alone, its eradication rate does not even reach 20% for H. pylori. even with the high sensitivity, even with the fact that it is secreted in the gastric juice, and even when we increase its dose to more than 2 grams, because we are seeing that we are using it 1 gram twice a day. But even if we increase the dose to more than 2 grams, it does not increase its eradication rate of H. pylori. So, but the good thing with it is that resistance of H. pylori to amoxicillin is very low, is very insignificant. That's why we want to include it in all our combinations. Another reason why we want to include it is that when amoxicillin is combined with a PPI, like omeprazole, is that it increases the eradication rate of H. pylori to a percentage that is so surprising. That's why you will see that in all our combination therapies, we are adding the amoxicillin. Now, that would be our triple therapy as per the guideline, like Uganda clinical guideline. But then with clarithromycin, we see that there is an emerging resistance from H. pylori, and that is one of the major reasons why we are having patients failing to heal from peptic ulcer diseases. Now that is where we have an alternative, the azithromycin. Azithromycin becomes an alternative to clarithromycin. We are aware that both of them belong to the macrolide group. But let's take a look at the fourth Maastricht Consensus Conference report of 2010, where over 44 experts from 24 countries examined diagnostic and therapeutics that is related to gastroduodenal diseases, and they came up with a recommendation. That research was done from South Africa. They came up with recommendations on azithromycin after research had been done, that given our financial constraint as Africa, for example, now we are in Uganda, azithromycin now becomes a potentially less costly and yet effective alternative to clarithromycin with less side effects and less resistance profile. Yes, because from the various research on azithromycin and H. pylori, we find that at higher dose, azithromycin, at higher dose when used for shorter duration, that is 1 gram of azithromycin per day, OD, azithromycin's efficacy on eradication of H. pylori exceeds that of clarithromycin. So we have that other triple therapy, which is azithromycin based. That is azithromycin 1 gram OD for 3 days, that is a high dose and short course, plus amoxicillin 1 gram twice a day, which goes for 10 to 14 days, and a PPI. The PPI, of course, we are aware we do it twice a day also. We are saying preferably maybe we can use esomeprazole, though it's a bit expensive compared to the omeprazole. But we still do it also twice a day. That is, if we have used the esomeprazole 40 milligrams twice a day for 10 to 14 days. So this therapy gives us a greater eradication rate compared to the clarithromycin based therapy, and yet at lower dose when used for longer duration, azithromycin has efficacy that is similar to that of clarithromycin. For example, what are we saying? We are saying when we do azithromycin 500 milligrams once a day for a week, we add there a PPI for 10 to 14 days plus amoxicillin for 10 to 14 days. When we do this therapy like that, the efficacy on eradication of H. pylori is similar to that of clarithromycin. If we are having that similarity in efficacy, or even at higher dose being having a higher eradication rate, and yet we are saying azithromycin first of all is cheaper than clarithromycin, it is having less side effects, and then it is having less resistance profile. So that is where the fourth Maastricht Consensus report came up with such a recommendation that for cases where we are having financial constraint, azithromycin becomes a potentially less costly yet effective alternative to clarithromycin with less side effects and less resistance profile. We should note that azithromycin, if we use it at low dose, it is bactericidal. And yet when we use it at a higher dose, it is bacterial. Sorry, you will forgive me. When we use, you will pardon me, that azithromycin, when used at lower dose, it is bacteriostatic. Yet when we use it at a higher dose, it is bactericidal. Another advantage is that we should note that azithromycin has a very long half-life. For example, the 3-day course, which is 1 gram OD, or 1 gram once a day, it has a half-life up to about 71.8 hours. And the one for 5-day course, which is the low dose, has a half-life of about 68.9 hours. Meaning the H. pylori is going to be subjected to a constant enough amount of the antibiotic. So that is an alternative to the clarithromycin-based therapy. So you have been doing treatment and the patient is not responding, or you want to give the patient good medication combination, but the money isn't that good, azithromycin-based therapy becomes an option. And we have seen that it is so effective. But what happens where this first line is failing? That is where we go to second line, or where you find other guidelines saying the salvage regimen. In the salvage regimen is where a patient has been exposed to macrolides before. Such a patient has used a clarithromycin-based therapy before, or such a patient is resistant to, is allergic to penicillins. If we interact with our patients, we will find out that most of them have been using the H. pylori kits, the kits that are being sold now because they are so abundant. And we find that most of these kits have clarithromycin, although they have clarithromycin of 250 milligrams, but most of them have it. So that is where our second line comes in, or the salvage regimen. The salvage regimen, we have two regimens. Number one is having a levofloxacin-based sequential therapy. If you notice me, I'm trying to be careful with my word that it is a levofloxacin-based sequential therapy. Then the second one is where we are having the bismuth-based quadruple therapy. So let's look at the first one, the levofloxacin-based sequential therapy. Number one, this therapy has an eradication rate of about 92.2% for H. pylori, and then it is superior to the clarithromycin-based and tetracycline-based therapies. That's the levofloxacin-based sequential therapy. How do we do it? This one here, we do it sequentially in a way that for the first 1 week, that is 7 days, we give a PPI, maybe preferably esomeprazole. We do it 40 milligrams twice a day, plus amoxicillin, which is 1 gram twice a day. We do it for a week. Then after that week, we still continue with our PPI, but now we add there a metronidazole, 400 milligrams or 500 milligrams BID. For the case of Uganda, our formulation is majorly 400, can be made to 400, because as we said, our metronidazoles are 200 milligrams. So we do metronidazole 400 milligrams BID. Then we add a levofloxacin in the combination. We are adding levofloxacin either 250 milligrams or 500 milligrams BID for another week. So we see that the first 1 week we are doing a combination of two drugs, a PPI plus amoxicillin. Then after that week, the following week, we are doing a combination of three, a PPI, a metronidazole, and a levofloxacin. And this is what we are calling the levofloxacin-based sequential therapy. And we are saying it is superior to the clarithromycin-based and even the tetracycline-based therapy. And we are saying it is having a very high eradication rate for H. pylori. We should, however, note that in this combination, the levofloxacin of 250 milligrams surprisingly has a higher cure rate compared to the 500 milligrams. That is the levofloxacin-based sequential therapy. Then we go to the next. The next therapy is the bismuth-based quadruple therapy. In this one, we do a PPI, that is twice a day. We add a tetracycline, 500 milligrams. Then we add a metronidazole, 400 or 500 milligrams, depending on your country or location. Then we add the bismuth. The bismuth here, bismuth, we have so many formulations for bismuth, because we have bismuth subcitrate, which is 240. We have bismuth potassium citrate, which is 220. We have bismuth tripotassium dicitrate. But whatever it is, leaving out the PPI, these 3 drugs, we do them 6 hourly for 10 to 14 days. That is the bismuth-based quadruple therapy. But now, for this particular therapy, maybe we can take a look at an article that was of the Lancet Gastroenterology and Hepatology. It was in the Science Direct website. This was an article of 2023, where they used a bismuth tripotassium dicitrate, 300 milligrams, 6 hourly. They added the PPI. They used the omeprazole. They used esomeprazole, 40 milligrams twice a day. Then they used tetracycline, 500 milligrams, 6 hourly. Then they used metronidazole, 500 milligrams, 6 hourly, and was given for 10 days. And the result was really amazing. So these 2 therapies are what we are calling our second line, or the salvage the salvage regimen. But then a doctor will say, I've done all these, but things have not changed. The peptic ulcer disease is not going. The H. pylori keeps reacting when tested. What do we do? Well, we have what we call the furazolidone-based rescue therapy. Maybe someone could say it is the third line. Furazolidone is an antibiotic. It is a nitrofuran. So we have a therapy that we call a furazolidone-based rescue therapy for peptic ulcer disease that is resistant. A patient has had multiple treatment failures, but the H. pylori has refused to be eradicated. So what do? In this therapy, we get amoxicillin 1 gram twice a day. We add a PPI or omeprazole 20 milligrams twice a day. We add furazolidone 100 milligrams or 200 milligrams twice a day. Then we add a bismuth subcitrate 240 milligrams, and this treatment goes for 2 weeks. This combination, it is a quadruple therapy. It's what we are calling a furazolidone-based rescue therapy. Yes. This therapy it has been researched about. For example, let us take a look at an article that was posted in 2021. Of course, there are so many research, but let me take this particular one. It was posted by Elena Resina and her friends. It was about a research where all patients had previously received bismuth and the key antibiotics that are used in H. pylori treatment. Which ones are we saying? We are saying they had received amoxicillin, they had received clarithromycin, they had received metronidazole, they had received levofloxacin, they had received tetracycline, they had received rifabutin. And these patients, all that were used in the research, had 5 or more consecutive treatment failures for H. pylori eradication. Yes, they had 5 or more treatment failures that were consecutive, and all of them had H. pylori that was positive on culture, on their stool culture. So that was a clear case of resistance after 5 or more treatment failures. So what were the findings? The findings as per this article was that, as per protocol and intention to treat eradication rate, it was up to about 63%. That was the cure rate or eradication rate, and with less adverse effects in patients who had 5 or more consecutive treatment failures. Therefore, we are saying for furazolidone-based rescue therapy, will now constitute a valid, a safe and affordable strategy, and it is one of the few options after multiple previous eradication failure with key antibiotics. That's why we are saying that, okay, we have done all the antibiotics, we have done all the combination therapies, the H. pylori has been persistent, we are failing to eradicate it. Then we go to the furazolidone based rescue therapy. So these are the challenges for peptic ulcer diseases. That H. pylori eradication is one major challenge. So we have looked at the H. pylori. Let us look at another thing. We are looking at healing the wound, because we have said peptic ulcer disease or gastritis means our patients are having wounds in the stomach. How do we heal this wound? Number one, the obvious one, that we reduce the acidity in the stomach. Reducing acidity, we use two things. The H2 receptor antagonists, for example, the famotidine, ranitidine, though we see that ranitidine in countries like where the FDA is working, it was discontinued during COVID, but we have other products like famotidine. Then we have the PPI. The PPI, we have been singing about them, amoxicillin, esomeprazole, pantoprazole. But now we see that PPIs are superior to the H2 receptor antagonist in healing and efficacy, even in eradication of the H. pylori. We go to the next, that we should neutralize the acid. Neutralizing the acid, we use what we call antacids. These antacids, for example, we have aluminum hydroxide, we have magnesium hydroxide, we have calcium carbonate, we have sodium bicarbonate. These products are used to neutralize the acids within our stomach, but the challenge is that they are required in larger dosages for good results, and yet they come with their own side effects. And we see that most of these antacids are found in syrup forms. Like for the case of my country, Uganda, you would easily find them in syrup forms. We have seen syrups like ulcers, they have these antacids. Then we go to another important factor, that how do we promote healing of the wound? That is where most of us leave out. We have a product called sucralfate. It is a compound called sucralfate. Sucralfate can be found in tablet or syrup form, but easily found in the syrup form. The tablet is given 1 gram 6 hourly. Also the syrup, you would prefer that, but the maintenance gets back to 12 hourly, 1 gram 12 hourly, or twice a day. But this compound sucralfate, we take it 2 hours before meal. In other words, we take it in an empty stomach. Or if we have already eaten, we can take an hour and then take it. The amazing thing with the sucralfate thing is that this sucralfate will form an ulcer adherent complex with the injured part of your stomach. When it forms that ulcer adherent complex, it protects against the acid, the pepsin, the bile salts. That is sucralfate. But also we are saying that besides it exhibiting that thing we are calling a cytoprotective effective effective layer, or a mucus layer, that mucus layer is viscous, and therefore it also protects the rest of the other stomach surfaces from any further injury. But also it's one other thing that we cannot forget, is that it stimulates the synthesis and release of gastric the gastric mucosal prostaglandin, bicarbonates, and above all, epidermal growth factor. The epidermal growth factor is what is necessary to stimulate the healing and formation of new healthy skin in the injured stomach, or in the injured part of our stomach. That is the sucralfate. So maybe there is a product that is available, like for the case of Uganda, we have a product called Sucrafil O-Gel. The Sucrafil O-Gel has sucralfate in it, and then it also has oxetacane. Oxetacane is for numbing. Then the sucralfate is what helps us to promote the healing. That is the part of healing the wound in the case of peptic ulcer disease. Then maybe in the treatments, doctor may decide to add in adjuvants. Adjuvants, we can add probiotics. adjuvants, we can add statins. For example, simvastatin has been proven that when added with other standard therapies, it can actually boost the healing of up from 62 to about 82%. So those are adjuvants. Then we have seen the use of antidepressants and anti-anxiety drugs. For example, we have amitriptyline, which is a TCA, being used in treatment of peptic ulcer disease and maybe inflammatory bowel diseases. Then we have chlordiazepoxide, which is a benzodiazepine, based in combination with clinidium. Clinidium is a muscarinic antagonist. For it helps in decreasing the acidity and also relaxing of the intestines. And we have products that have this combination of chlordiazepoxide and clinidium. For example, in Uganda, you would easily get a product called Epirax. Then we have Librax. These are so helpful when we are dealing with peptic ulcer disease, chronic gastritis, and inflammatory bowel diseases. Then, I think that is all. The challenges, we have handled them. The difficulty in eradication of the H. pylori and the difficulty in healing the wound that is from the chronic gastritis, chronic or resistant peptic ulcer disease,